going. In just a few minutes, that stream will be live. There it is. Okay, so we are now streaming on Facebook. Thank you everyone who's joining us there. I'm going to be saying a few words about NAMI-NYC to kick us off, and then I'll be turning it over to our presenter, Anthony, who is going to start off tonight's event. NAMI-NYC, the National Alliance on Mental Illness of New York City, is a grassroots mental health organization that provides support, education, and advocacy for all individuals and families impacted by mental illness. We're really excited to be co-hosting tonight's event with Gracie Square Hospital. But a little bit about our services. We have support groups, classes, and many other services that we are currently offering remotely through Zoom and through other remote platforms. You can find out more about all of the services that we're offering, including free peer-led support groups for people living with bipolar disorder, depression and anxiety, young adults, and so on and so forth. You can find out more about all of those groups by going to naminyc.org/calendar. And I'm going to put that in the chat as well for those of us joining on Zoom. You can also find out more by calling our helpline. That number is 212-684-3264, or by emailing us at helpline@naminyc.org. And I'm going to put that in the chat as well. We're really excited to be co-hosting this event, really focusing on the importance of overdose prevention, especially during in the time of COVID. So thank you all so much for joining us and for being here. And I'm going to turn it over to Anthony.
Thank you very much, Clara. My name is Anthony DeDonatis. I'm a psychiatric nurse practitioner here at Gracie Square Hospital. And one of the subspecialties here that I practice in is with addictions, a dual focus unit where we, again, focus on substance use and also mental health issue, co-occurring mental health issues. Today, our presentation is going to be just a little bit about a background about addiction, kind of the opioid crisis, some of the data, and some of the responses from the kind of the national organizations. And also this slide will also kind of reflect our response here at Gracie Square and our Naloxone project, at Gracie Square on our unit. So we actually can add a pilot program, which we'll briefly talk about. And as we were talking about earlier, there will be a presentation and questions and answers and things like that. So without further ado, there we go. And here's an anti-drug commercial from the 80s. I thought this was interesting just because I know everybody has seen this commercial probably. This is your brain on drugs. And I thought nothing else could sum it up even better in terms of addiction and actually what it does to the brain itself. Next slide is that, what is addiction ultimately? As I have it up here, the exact definition, it's a chronically relapsing disorder. And there are certain things that's characterized by which those that struggle with substance use disorders, you can see in terms of compulsion, the loss of control with these drugs. In addition to that, there is this negative state, either a withdrawal state or kind of this binge intoxication state. And this reoccurring cycle that happens, where it says preoccupation, the craving state. And, the cycle just continues and with what we see with the kind of 3 stages in addiction. Next slide. Okay, this all here, just basically, why are we addicted to anything, more or less? As you can see on here, we talk about natural rewards, stuff like running, exercising. We all kind of accumulate this kind of, we associate it with this very good feeling, like, the endorphin rush, things you hear like that, very common. And, and that's because of all the dopamine that's kind of going into our brains, this rush that we talk about, that feel-good system. Well, what happens with drugs, as you can see, it says about 2 to 10 times more chances of dopamine being entered into the brain. And what happens is over time, there are actually changes in our brain, and which is, again, going to talk about pieces of drug occupation, cravings, addiction, and withdrawal. So there's this kind of interruption in this circuit system in our brains. So again, without getting to all the science behind it, but this is where we believe the main reward system occurs in our brain. Next slide. And again, this is just more of the brain stuff in terms of, it's, as you see here, it says addictive drugs provide a shortcut, which is interesting. And that's exactly what it does. We keep we keep hitting up this reward system, and over time, like I said, even in the absence of the drugs, that craving still remains because your body and your mind and the physiology of it all kind of really adapted to the drug and having it in your system. Next slide. Again, this is just exactly what happens. It just, here it says dopamine and glutamate. So basically, those are kind of neurotransmitters that are in our brains that get stimulated here. And over time, that whole euphoric feeling that people have from the immediate drug use or drug abuse in that sense goes away over time. And as we know, people hear the word tolerance, and that was just kind of the background in terms of how that happens physiologically. Next slide. Just some information, some opioid crisis background. Now the leading cause of accidental death linked to increased opioid prescriptions, which I think, again, which was one of the most interesting markers of this. The drug diversion, as you can see, family, friends. I have a slide down in this presentation. You can kind of see the percentages of that. And individuals that escalate, we talk about the gateway drug, and we'll get into kind of a little bit what that looks like as we go along. Next slide. Again, more background. 5 million Americans report using prescription, and it might even be more. 2.5 million Americans beat for opioid dependence. In more recent news, kind of the big companies, Purdue Pharma, if people paid, saw in the newspaper, basically were sued because of these opioid prescriptions. Oh, where?
Somebody's not on mute.
Oops, sorry, can you guys hear? Okay, and just down here, another statistics, and this is 2016. Drug overdoses greater than motor vehicle accidents for leading cause of death, which is quite significant. Next slide. And what does a person that struggles with opioid use disorder? Well, I mean, it could vary, but again, this is typically what we see. A person that has a history of substance use disorder, high dosages of these medications, is male, older age, and what we find is multiple prescriptions and the co-occurring also psychiatric complications from the substance use. And the last piece is lower socioeconomic status. So services for these patients, particularly during the COVID, I think we talked about that. We're going to touch just a little bit about that, but I can tell you from our inpatient experiences, we had a lot of difficulty kind of reconnecting a lot of our patients that came in that struggled with opioid use disorders and other addiction, medications. Next slide. And again, this is just some of the demographics. As you can see, there's this dramatic increase in terms of heroin addiction over, and this is a 2013 slide. Down below is the MAT training that I took place to, in terms of me getting, Suboxone licensing, things like that. So there's this extensive training just to kind of go over all that. The next slide. And this is just kind of the breakdown. Misused opiate prescriptions that we see 56% free from a friend or even family member. And again, as you can see, the doctors, 19%, and others are stolen, 0 for internet, what I thought was interesting. Next slide. And this is just a picture of how embedded and heroin is in our society. And it was over the counter over 120 years ago. But as you can go down the next slide, we will find, the different types of opioids, opioids, and opiates. Just so I put that up there so everybody has an idea of the different types of opioid that you'll see either prescription or non-prescription. Next slide. And this is, again, that whole idea of the gateway drug kind of thing where it says most use at least 3 other drugs in addition to heroin. So you're looking at alcohol, marijuana, cocaine, and opioid painkillers. Why this is particularly important from our perspective is that when they come into the hospital, we're looking for these things and in terms of treatment, but it's not always so clear. So of course we do our drug testing and to see and kind of rule out these other substances that may be co-occurring with the use of opiates, which of course can be very, very deadly. And but again, this is just to give you an idea of when we receive patients that are struggling with opiate use disorder, other things that we need to be thinking about in addition to that, in addition to, of course, the mental health. Next slide, please. And this is interesting in that at one point, I can recall probably about 2-3 years ago, and this was a big thing, inpatient-wise, outpatient-wise. We were seeing a lot of mixing of the opiate, heroin, or oxycodone, or whatever opiate that we're using with fentanyl. and it almost would lead to instant death. I'm sure people have read about this in newspapers and certain articles that show the impact of how this drug is not only just with, singular, but they're adding other illicit drugs to it. And ultimately what happens here is what we found out from studies and also from our patients themselves. They would tell us a lot of these this happened without their knowledge, which is really obviously a very major health concern for our patients and for people in general. Next slide. This is just a historical context. As you can see, we used to have morphine clinics for opiate addicts back way, again, 100 years ago. As it moved up, down up to the 1970s, were the introduction of methadone maintenance programs. Those methadone maintenance programs received, was not well received initially, and still a lot of times, even to this day, a lot of our patients really struggle, attending these programs due to the stigma, and also in terms of depending on which neighborhood they live in, and kind of the, pieces there where it becomes very difficult sometimes for our patients to kind of actually get treatment. So, and that's, again, this is just some of the history behind it, the AMA, and our responses to opiate use. Next slide, please. Okay, just again, more data according to U.S. Drug Enforcement. Overdose, again, particularly prescription drugs, heroin, have reached epidemic levels, and that's kind of what this response is in response to. Again, we'll talk about that a little bit as we go along. Overdose, this is just more data. 2016, 64,000 drug overdoses. Opiates were responsible for 42,000 of those deaths. That's obviously quite significant. So again, causing more attention, not only to us here at Gracie, but nationally. And down here, we have the development of our what led us to wanting to do a pilot program on our floor to start teaching and administering NARCAN to our patients and their families. And we'll be talking about that and providing a demonstration soon. Next slide, please. Okay, and again, there's just more opioid overdose, kind of the risk factors that we're looking for. Injecting opioid users, opioid dependents. These are just things that we need to think about in terms of care. So it's not obviously just the opiates that they're potentially abusing, but others, comorbid conditions, and a lot of liver and kidney diseases. We see a lot of that. So a lot of our patients that come in here are highly medically compromised from many different angles. So we have to provide them not only in addition to psychiatric services, chemical dependency service, but a lot of times also referral services for medical follow-ups, which again, of course, in the COVID has been extremely challenging. And our patients, have spoken about that. And then, of course, trying to get people the care for this has been a lot of challenge. Okay, good. Next, I'm going too fast. I'm sorry about the opioid overdose. What does it look like? Respirations slow down, heart rate slows down. What you see here at 86%, that's our O2 levels in our blood. So we kind of see this, the hypotension, the pinpoint pupils, and the big thing, of course, is unconsciousness and this respiratory depression, which we'll talk about a little bit more. Next slide, please. This is the World Health Organization response. Ultimately, their plan, as our plan was, to provide people with these kits, education, getting it out to the communities that really need them, and kind of identifying those communities. World Health Organization took part of this. Next slide, please. As you can see, in 2006, and for us in New York State, for non-medical persons to administer these opiate overdose kits before becoming fatal, of course. And down here it says a recent survey in the United States found that approximately 50,000 kits result in more than 10,000 reverses in overdose, which was quite significant and leading us to where we are today using these programs. Next slide, please. This is just more responses, in terms of what does treatment actually look like. Psychosocial intervention, that could be from anything from counseling, meeting up with case managers, therapists, social workers, etc. Social skills training, again, using your resources, community resources. A lot of times when patients are discharged, we talk about this, how to live their lives with their understanding that addiction doesn't just go away. Also educating the family, the group, getting them here inpatient to really kind of discuss with the family members and educate the family members regarding the impact of addiction and it's kind of how we treat it across kind of the lifespan. Down there, this is just the ASAM, American Society of Addiction Medicine. Again, another group, big group that just really is on board with getting people out the NARCAN, Naloxone treatments. Next. National Safety Council. This was interesting just because, again, these are all things that were added to practice for prescribers, mandating prescriber pain management education, education about opioid use, opioid dependence, abuse, things like that. Again, and how do we integrate these systems into not only inpatient but outpatient? What does that look like? And ultimately leading to more improving data and data collection and analysis. Ultimately, it resulted into increasing availability of the treatment of opiate use disorders, and one being that not just just medical doctors and also nurse practitioners, PAs can all kind of partake in helping combat this very insidious illness across the board. And yes, next slide, please. The Harm Reduction Coalition, and that's just in the United States. Again, this is just an advocacy group, not just an advocacy group. It actually specific targeting these groups with comorbid mental health disorders, in addition to comorbid medical illnesses as well. Next. Again, more data. In 2014, they conducted a survey, and they gave out about 152,000, as you can see, 283 kits, and overdose reversals, about a good result, 26,000 reversals, just from this kind of proactive way in our national response to the opiate overdose. Next. Good Samaritan law. So this is was in place to, again, for people, those who are in the community, they're worried about if something were to happen to someone that they were trying to help. You are certainly protected by the Good Samaritan law, and there's a Good Samaritan law, and there's certain provisions. So the next slide, we'll talk about those provisions. I just gave an example. This one is in Massachusetts. It just basically shows you piece by piece of how people are protected: patient protection, prescriber, doctor, nurse practitioner, etc. Those that are prescribing these interventions are protected by the law. So, and that is it. Next slide. Okay, so before we go on, I know there's a lot of information. I guess we can do some questions before the next piece here is where Joe Velasco, one of our nurses, is going to demonstrate the NARCAN project.
Awesome. Thank you, Anthony. There have been a number of questions, so I would, I'll pass some of those on, but feel free to add more questions for audience members. Please feel free to add more questions into the chat. One question that we've gotten that I think is important to start with, because I think the answer may be a little bit long. From your point of view, what should providers treat first? The substance use disorder or other mental health diagnosis someone might have that creates the possibility of them using? So when you have those overlapping issues, what's the approach?
No, excellent question. That is absolutely the immediate challenge when we have patients who come to us. We have to immediately, kind of gauge and use, of course, diagnostic assessment to rule out certain, to know whether it's a substance-induced episode, whether, there's co-occurring mental illness. So it starts with a very comprehensive assessment. Of course, the history of substance use, a history of psychiatric mental illness. So there is kind of this, again, kind of going through, depending on whatever substances that they're struggling with, we go through their history. We go through, whether they had a mental illness, and again, going through their medical comorbidities as well. So as you can see, there's many treatment arms we're actually treating when patients do come in. And sometimes that rule out doesn't occur until a couple of days actually from initial use of drugs itself. And then we can actually start to see differences. We can see whether it's, substance use. The patient within, let's say, I'll give you an example, is better within 3 or 4 days from, let's say, cocaine intoxication. Again, oversimplifying a very complicated assessment matter is that, we can kind of say in many ways that we think it's more substance induced, We also can see in terms of labs that we draw not only just the drug testing, but we look at the entire picture, kidney function. The whole thing kind of gives us an idea of substances patients that they may have used, they have not used, things like that. So, you know, there's a lot of factors that go into this, but if we start to see that there is a comorbid mental illness, typically that will last longer than the initial substance use, you know, intoxication. Does that make like clear? I know it's a lot. It is the loaded question, but ultimately we go through steps to do these rule outs. So patients that come to us first, because it's, you know, we're primary substance and chemical dependency, primary substance and mental health, we're looking for substance rule outs first. And depending on the drugs that they may have used, we use that type of assessment, and then we slide over to see if there's any comorbid mental illness.
Great. Another question from the related question. What are the most prominent substances that folks who live with mental illness struggle with in terms of addiction?
It's another great question. I mean, you know, and again, just from clinical experience, alcohol is always in the picture, almost always. Marijuana use, okay? We're going to get passing the political aspect of this. So we see that a lot, marijuana use, abuse. We see cocaine a lot, cocaine intoxication. So I see this a lot, you know, in addition to the opiate use disorder itself. We see all these, just like that one slide was kind of saying, we actually see that full spectrum of potential substance use disorders. So yeah, so the answer, the short answer for this is that there is a somewhat complicated exhaustive process to kind of continue to rule these out. And the patient, you know, again, depending on their state at the time, you know, we see collateral and things like that to find out more information about this patient, but, you know, it could take some time to rule things out.
Makes sense.
Yeah.
Follow-up question about that. Do you see people, is methamphetamines also a common co-occurring substance use issue?
The answer is yes. Interestingly, it's interesting you bring that up. I've noticed kind of a trend in kind of what we'll call an uptick and that, you know, that drug plus opiates this past year. You know, again, patients will tell you varied things. It's easier to get, it's cheaper to get. So that's kind of the common theme with some of these drugs. They're just easier to get or they're cheaper to get. So, so we see a lot of this. And again, just like anything else with mixing these drugs, we're you know, a lot of assessments, teasing that out certainly takes some time to do. So ultimately, patients will come in, we treat any sort of withdrawal symptom, whatever you know, whatever substances that they struggle with. We're noting that, of course, in our assessment, and then we immediately start to do some rule outs whether they're suffering from, you know, depression, bipolar disorder. So, and there are trends within that assessment as well that we start to see. Patients with, let's say, major depressive disorder and things like that. We know with major depression, there is again, when I talked about those dopamine systems, there's a major depletion in that part of the brain with depression. So patients, a lot of times you'll see, they'll come in, and they'll tell you, the only way I can deal with my depression is using stimulants. And stimulant, it could be, you know, a prescription stimulant, but more or less something like cocaine. So we kind of see these trends within certain diagnoses. Again, there's no one specific for everything, but again, we do see this commonly.
So there were a couple of questions about the NARCAN/Naloxone.
Okay.
It was addressed in the chat. Someone asked, what's the difference between Naloxone and NARCAN? It looks like that was answered,
Okay.
that Naloxone is the generic of NARCAN. There's also a question about if someone were to come across someone experiencing a heroin overdose, but who is also under the influence of alcohol, would the NARCAN still be effective?
Repeat that, I'm sorry.
If someone is experiencing a heroin overdose or an opioid overdose, but
Mm-hmm.
they're also under the influence of alcohol,
Mm-hmm.
how does that impact the overdose?
Great question. So long as, again, the opiate piece is important. If the patient overdose on an opiate, it will work. Okay, now the, you know, percent binding and things like that, how much, you know, might be a little bit less, but Again, there's other doses in that kit. If you need, you can use it, but absolutely. So Joe's going to talk about a little bit more about this, but I can tell you right now, the medication itself just basically takes, the opiate itself right off the receptor and ultimately still works. So the answer is yes, it does still work, but it's only for opiates. So if someone tries to give someone Narcan who overdoses on cocaine, not going to work. It's very specific drug. The mechanism and how it works, it's specific to the opiates.
Perfect. I think that's all the questions that were sort of on the docket already in the chat. Yes, thank you. An additional clarification, it works for opiates, but will not be harmful if
Correct.
It's something else.
Yes.
Yeah. But if there are other questions, now is a great time for folks want to put more questions in the chat. For folks who may not be familiar, the chat button, if you're on a laptop or a computer, the chat button is at the bottom of the screen. There's a little bubble that says chat, and you can click on that, and it should pop up a chat. If you're on your phone, there's 3 dots at the bottom right-hand corner of your screen, and if you tap that, you'll get a menu, and chat should be at the top of the menu. So now is a great time to, if there are additional questions or things that folks would like to hear more about, now is the time. And I'll let folks. Great. So thank you. There's a question about if we can send out a copy of the materials and the recording of the event. We are unfortunately not able to share slides after the event, but an email will be going out to everyone who registered for the event with some links to additional resources, including these just links to where you can find out more of this information. Also, the recording of this event will be available on the NAMI-NYC Facebook page, which will be a recording of just the presentation that Anthony just did. It will not include the actual overdose prevention training. This live stream will be ending before we reach that point. But the recording of this portion that you just saw will be available on Facebook as soon as the event is over. A question about dopamine and brain structure.
Sure.
Where are dopamine receptors located? Is it the front or back of the brain? How does that sort of work?
So again, this is, I'm oversimplifying this, but yeah, the prefrontal cortex. So when it works in our what's called mesolimbic pathway, and those brain centers are responsible for memory, executive functioning, as we were talking about today, addiction. So what happens is with overuse of these drugs over time affects our ability to make decisions, our ability to, impairs our memory. So I can give you an example with that. Patients that struggle with benzodependence, we're finding more and more things like that that is causing long-term memory issues. So there's going to be a lot more literature, I'm sure, on this as we find more and more information about it. But these are things that we're starting to kind of see. And that's, again, from the prescription standpoint. So yeah, so the prefrontal cortex and the mesolimbic system, those are the two. You'll find dopamine kind of in your brain, and of course, certain pathways. And what I have to make very clear here is that with addiction, it's not a matter of like different types, but the amount that you're flooding your system with. So ultimately, you start over flooding your system, just like anything else. It burns out, and those kind of have to have some sort of genesis, and that comes with either recovery, time away from the drugs, and in some instances, over time, it may or may not come back to what it used to be. So I don't try to scare my patients when I say that, of course, but it is a reality. Sometimes we see these organic changes over time. And so when you compare them from when they were 20 versus 50, 56 years old, you see these kind of impairments.
Can you talk a little bit more about that? There was a question in the chat of, can the brain recover from this? Yeah, I think it would be great if you could talk more about recovery.
Yeah, of course. So again, just an example would be naloxone, which I know the words, but yeah, over time, ultimately, more time away from the drugs, the brain does heal. However, there are actual RNA, DNA changes with heroin. They've learned this they've learned this a long time ago, but again, trying to kind of make people understand just ultimately what parts of your function overall daily living is it going to affect. And many people, of course, is memory and just overall cognition. Your ability to make decisions is impaired. So, so that's really kind of the impact of drug abuse.
Awesome. So we have just maybe two more minutes for questions. So I want to give folks a chance to ask any additional questions that they may have. I see that there have been a couple of questions about sending out the kits and the way that that's going to work. So I'm going to take this opportunity to sort of address that while we see if there are any more questions about addiction more generally that are coming in. So we are sending out kits to folks who, this is the first part of the event. The next section of the event, which we're going to get started on around 6:45, is going to be the actual overdose prevention training that will train you on how to use a NARCAN or naloxone kit. We will be pausing before we go to that to allow folks who are not specifically attending that training to jump off the Zoom room, and we will also be stopping the Facebook live stream at that point. In order to be eligible to receive the naloxone kit, you must have your camera on, and we will be taking attendance. We are unfortunately only able to send kits to the first 40 people who registered and also attended the event. So we're going to see how many people are still on the call once that training starts, and we'll be taking attendance and making sure that we send out, all the kits that we're able to those that need it most. Yes, so hopefully that addresses some of those questions. There are, it looks like, this is a great question about methadone maintenance, which I think would be this is a good point to address that. What options do people have to get off methadone if they choose to?
Great question. There are many factors involved here. So methadone maintenance programs, the patient is enrolled in a federally regulated program. So for a couple things that have to happen here. If a patient has some sort of physiological altered response, would be something like cardiac disease. They're more prone to having certain elevations and certain toxicity from the drug. Particularly the evidence is saying that people over 50 typically should try to get off of methadone because of the cardiac complications. So that's really one of the big things. So if there's a medical reason to get someone off methadone, certainly there is a process where we can taper them off. Inpatient-wise, I can tell you, is that we want to use Suboxone, but again, that transfer, depending on how much that dose is the patient comes on, we kind of transition them into and starting them Suboxone treatment. So we can actually do the induction, but it doesn't really happen a lot inpatient, just because if a patient is on 120 milligrams, 130 milligrams, it takes could take longer in terms of the tapering of that drug plus the transition. So this you might see at a more long-term residential treatment, but also it involves communicating with those methadone programs for this patient, and that is something that the patient is interested in doing and absolutely can come off it. So the methadone transitions to Suboxone, and if you decide never to use opiates ever again, that kind of thing. I mean, naltrexone just is the absolute, but again, ultimately you can get to either or. But generally speaking, it'll be most likely Suboxone, but there is this kind of tapering process and communication with the methadone programs itself. which is very important because I think a lot of times patients sometimes do want to come off of the methadone, and which is fine. But again, it just depends on how much they're on, how much time they're going to be inpatient. And going back to that first question I was asked about comorbidity with psychiatric illness. So let's say a patient is here for bipolar disorder as well. You know, they may be here long enough for a actual taper, but that's something to, again, to be addressed almost immediately in the early stages, and also when we look at a patient's medical history.
Perfect. All right, so it's 6:45. There was a question, I think this is a good one to end on, about if folks have follow-up questions. I'm going to be putting my email in the chat, and folks are welcome to reach out to me if you have any follow-up questions, or if you have any additional thoughts or concerns. That is CKIELY@NAMI-NYC.org. Anthony, I don't know if you have any sort of things that you want to say in closing to this portion of the presentation.
No, I just want to thank everybody for coming and listening to our discussion tonight. We think obviously it's a very important topic, and our response to the opioid crisis, again, our efforts here at Gracie Square, it was again, a priority for us here. And modestly speaking, I think that our patients, certainly it's been receptive with them and their families. Thank you, guys.
Okay, so at this point, we're going to go ahead and transition to the overdose prevention training. So we will be stopping the live stream.